Welcome back, episode 17. Here we go. A few good physios.
Few good physios. Today's going to be a shorter session.
It's going to be special, though.
But a very special a very special, can't speak, jiu-jitsu brain. Insurance is the topic of the day.
Yes.
The good, the bad, and mostly the ugly. We will start off, well, we'll get a little personal with the day in review, the week in review.
Week in review.
Lee broke the ice today. I'll let him tell you what's going on.
Yeah, so I'm back at jiu-jitsu. Went today. In our classes, they split it up in the beginning. It's starting with standing work, then you go through some drills, then you go into live rolling, and there's multiple rounds of live rolling. So I did not do the live rolling. So I just did the standing and the drilling, and it was really hard. I was telling Eric before we started. I kept it in my head 2 days ago that I wasn't gonna roll. I'm not gonna roll. So as soon as Mr. Danaher said, "All right, get ready for live rolling," I was like, "All right, see you later, bye."
That's great. And that room today, just to give you guys, for anybody that anybody watches jiu-jitsu or MMA, they had a GSP, and what was the other guy's name?
Craig Jones was there.
Yeah, amongst other.
There was
elite
somebody else
fighters.
there. I can't remember who it was, but somebody else famous. That room was just full of incredible people.
Top level, yes.
Yeah.
So it's congratulations, breaking the ice.
Yeah, thanks, man.
He's back in the loop.
There'll be more to come, I'm sure. My neck felt great, even though I got rolled back a couple of times. It felt really good.
Yeah, I mean,
So.
the first day back after a long weekend. So, but not as exciting as that room. So
That's
in and
cool.
out of network, let's make some distinctions here. So everybody in theory knows a little about insurance, but unfortunately, if you talk to 5 different people, you'll probably get 5 different answers. And hopefully, at the end of this podcast, you'll be able to have some of the basic lingo and terms. But the nature of insurance is confusion, so it may not make sense to you.
Yeah.
Reach out, let us know if you have any questions. But this is obviously from our understanding, and just in the 8 years of us practicing physical therapy, things have changed quite a bit, and not on the positive side for a provider or a practice, private practice, large practice, you name it. I mean, for the consumer and the provider, things have been somewhat compromised by the day. But if you own any kind of healthcare stocks, you're doing very well, because healthcare companies are doing very well these days. So, Lee, what's in network? What's out of network?
That's a good question. So there is 2 major categories of when you have insurance benefits. So let's start with in-network. In-network insurance benefits are benefits that you can receive that the insurance companies basically have vetted. I'm going to put that in a quotation. They have, quote, vetted, and that they can be ranging from physicians to physical therapy clinics,
Dental practices,
any other
Folks.
rehab facilities. Not pharmacy. Pharmacies don't fall in the
I don't think so. No,
category of this.
they're
because they're not in and out of network.
no, they're not in and out, but they have their own little system of generics and name brands, and insurance companies could dictate which medications they cover, but that we're not as familiar with those terms.
Right. So once they have, quote, vetted these institutions, then they can somewhat dictate their reimbursement rates to these places. So usually these places, they'll go in contract with these insurance companies. And so what that means is they agree upon a certain reimbursement rate for a certain service. And then the unfortunate thing is in these contracts, they're pretty binding. They're binding in the sense that they're not like per month, per 6 months, per 3 months. They're usually for a year.
Per year, and there's often inclusions that have automatic renewals, but which obviously can be, debated in court. But yeah, most of these insurance companies, they do have like these reoccurring contracts. Now, pros and cons. Typically an in-network facility, as Lee said, vetted, credentialed. They use a lot of different terminologies. Basically, the insurance companies sees that your practice is, I don't even know. I want to say legit, but I don't.
But it's
That's
not
not.
even. It
No,
doesn't
no,
even.
no, no. We can't even. We can't say that because we do know of many. I mean, unfortunately, we've discussed this in previous podcasts. There are many in-network practices that don't really practice physical therapy. So
Correct.
they do something else.
Ultrasound and
E-stim, shake and bake, shake and bake. So they go through this process, but the big kicker here is this negotiated rate amongst the provider and the company. Now, I've never been through a situation where through that, but through hearing stuff through colleagues, and passing in the last 8 years in New York City, these rates are okay, but usually they're not good enough to sustain a practice. This is why most in-network practices do have to see a higher volume of patients in order to cover expenses and put some food on their table.
Mm-hmm.
So in-network, this is really a contracted rate. A lot of hospitals are in-network, and the larger the institution, the larger leveraging power they have with the insurance companies. So insurance companies, give a better rate at this higher volume. And I'm making a lot of assumptions here because I don't know the intricacies, but that's how it is. So in network, it's pretty much deductible, usually when you utilize in-network services as a patient, you typically pay a copayment. And that copayment, here in New York City could range from anywhere from $20 to $75, right?
Mm-hmm.
I mean,
big
it's a big gap, in some cases even more. A lot of employers give their employees options on insurance, and a lot of them just may cover in-network services because they are cheaper plans if you just choose in-network benefits. I'll let Lee elaborate a little on that.
I have two questions. The copay, that copay is going towards their in-network deductible, or no? That's just their
No, that's the agreeable rate with the patient and the insurance company that they would only pay X amount if they see an in-network provider.
Gotcha.
I don't think that goes toward a deductible, although it probably. That's a good question.
Yeah, I don't know.
I'm not sure. That might just be a cost, and with the contracted rate, that's kind of probably packaged in somehow.
Yeah, and I did want to touch upon why, I think there's a lot of confusion in the physical therapy world from a patient who's not familiar with these things, why they see a PT in an in-network setting for a certain amount of time. Well, as Eric was saying, usually to sustain a workable practice, because of the small reimbursement or the less than optimal reimbursement rates they have to see more patients to sustain the practice. So that includes rent, salaries, things like that. So they typically, in general, you're going to find the quality that you're getting for physical therapy is not fantastic. And you'll probably get more things like ultrasound and e-stim and all the passive modalities. So that's typically in an in-network clinic.
Yeah. And some of the in-network, here in New York City, there's a lot of large institutions, particularly hospital groups. These larger hospitals do have a little more. They have varied practices. They have, they do the ultrasound and e-stim, but within that, they do have some providers that are doing some great work, and they have a decent amount of time to work with patients. And again, this is because they're a larger institution and have a lot more leverage in getting enough resources to not see as many patients.
Right. So if you have car insurance, you know that a deductible, if you hear the word deductible, that means like, oh, you have to pay, like say you get into a car accident with car insurance, you have to pay a certain amount of money before your health insurance kicks in to, let's say, repair your car, replace your car, whatever it may be. So the higher the deductible, the not so great your situation is.
Right. So, and that's the same here with health insurance. So
right.
a disturbing, alarming trend for patients is that in the recent years, deductibles have skyrocketed, right? We all know, if you picked up a newspaper, that premiums have gone up, somewhat astronomically since the last 10 years, I would say.
Yeah.
But the deductible has as well. So, typically, I'm going to make a lot of generalizations. 10 years ago, 8 years ago, you might have had $250 deductible, up to $1,000 deductible, and some in-network policies. Those have gone to $8,000.
I can use my insurance
Yep.
as an example. So for all of you, I'm going to disclose some information. I have an $8,000 deductible, and then I have a $16,000 out-of-pocket max, and that is quite a lot.
Yeah.
And I have sought out-of-network care this year on several occasions, so it wasn't covered by insurance, which I was fine with because I'm much better now.
Right. So, you get what you pay for. Lee paid out of pocket for his quality care and didn't have to see his therapist 20 times.
No, it was actually 3.
Wow.
Or not even.
And he's back on the mats.
And I had a serious, in the category of, like, if we were to see a patient who had frank motor weakness or neurological weakness,
Serious.
that would be serious. That would be like we would be saying to this person, it would be great to get an MRI or go see your doctor. And, because I saw a skilled clinician, they knew what to do, and they gave me those recommendations, and I went through the right course. And now non-surgically, I'm doing okay, and I'm going to continue to get better and get back to the activities that I was doing before.
Yeah, so in-network deductibles, premiums have gone up, deductibles have gone up, and what you're actually getting has gone down, way down in terms of the quality of care. You take a look at the average doctor, right? The doctors are unfortunately subject to these forces as well. And doctors, are often all double booking, triple booking, seeing patients for about 2.5 minutes. I'm making a lot of generalizations, but if any of you guys have been to certain doctors, you've experienced a short visit. And, unfortunately, the doctors are trying to survive, I think. I mean, they're trying to keep things afloat.
Yeah.
So all of these forces are affecting the quality of care. Now, going into out-of-network benefits, that is you dealing with the provider that does not have a contract with the insurance. What this means typically is a higher deductible. So those high deductibles that we were mentioning can go higher. It also means that the provider can charge whatever the market rate is, and the insurance company arbitrarily kind of goes with what the market rate is to reimburse this provider. Things change quite rapidly, as Lee and I were discussing before. So stuff that we knew, well, if we made this podcast on how to optimize, reimbursement rate, or how to optimize, basically how to navigate the system, tomorrow it could change. And that's part of the problem, that, the rules, or not even the rules, the private insurance policies change pretty quickly.
Yeah. It's so weird. I'm just thinking about it right now, but I think people have to know, even if they think about it, what we just said, you don't always, the insurance companies are selling this in-network idea, because I've gotten emails from my insurance company, and they're like, they list off these bullet points of what the benefits are of seeing an in-network person, and I'm like, none of those are true. Absolutely none of those are true. They're talking about better quality, clinics that we have credentialed and things like that. Out-of-network providers, I don't know how many out-of-network providers that that provide suboptimal care.
They wouldn't survive.
They wouldn't survive, right? So like that's what it's so backwards in terms of how they're selling it.
Yeah. So in a lot of cases, out-of-network providers don't even bill insurances, right? There's a lot of providers here in New York City that charge cash and give a receipt to their patient. And then the patient unfortunately has to navigate the maze of reimbursement. Now, within insurance policies, there's a wide variety of policies, and obviously, you kind of get what you pay for
Yeah.
to some extent. So some of these, higher end policies do have out of network benefits and don't haggle the provider or the patient in the situation. It's a rare situation. Here in New York City, there's a lot of wealth and a lot of dispendable income, but it's still a situation. So out of network providers do not have a contract. Patients are free to see, if they have out of network benefits, they're free to see anybody they want, and just be subject to the provider's costs. So yeah, like Lee was saying, if you're an out of network provider and you're providing suboptimal treatment or care, let's just put it that way, it sifts you out. So if someone has to pay out of pocket $150, $250 for a visit, and they don't feel like they're getting taken care of. So out of network is definitely more of a service. It's not more of a service. It shouldn't be. I mean,
it's yeah. All right. So you're going to be putting forth your money that would otherwise be covered by insurance companies. So it's going to be definitely more noticeable when you go get treatment. And if you go there, it's going to have a bigger impact on your own, quote, economy.
right.
So it'll be a little bit more, if you're not getting better in a certain amount of visits, and or you're not getting information that you need, you're gonna, as a human, you're gonna want to go somewhere else.
Right. And then just some generalizations and some observations of in-network versus out-of-network. The big thing here as a patient is you will notice time with your provider. Now, most in-network practices, they range from seeing a patient for 3 minutes upwards of 30. And 30 minutes are those large institutions that we're discussing, like major hospitals here in New York City.
Mm-hmm.
The reverse, the 2 or 3 minute treatment is some large physical therapy practices, maybe even a national practice. And again, I don't think Lee and I mean, I'll speak for myself, but I'm sure Lee would agree that it's really not physical therapy. And unfortunately, when you hear a patient said, well, this is different, you're actually talking to me, you're spending time. The big difference is time the patient is with the person. So that fortunately and unfortunately means that there's a cost associated with that, right? The longer you are with a provider, the more it's probably going to cost you.
Mm-hmm. Yeah. And then I was... just to mention that too is this is something that I feel like is one of the key components of the out-of-network model, is the fact that you can spend more time, you can build a better relationship. Yes, quote, services being going back and forth, but the biggest thing is, are you choosing to have this relationship that involves more focus on you and all the aspects of your injury and your situation, or are you going to go see someone who's going to have a nice short relationship with you, in a sense that they don't really look at anything except for how long they can ultrasound you, because it's based on how many units they could see you for, real quick, to talk about the deductible and how it would work in out-of-network, I mentioned I had an $8,000 deductible, so that means I pay cash up front until I hit the $8,000. And then what kicks in after that is something called co-insurance. Right. So you got, every plan will have a difference. I don't even know what my co-insurance is, but let's say it's 80-20.
Right.
So that means they're going to cover 80% and I have to pay 20% per data service or per service. So let's say we'll use it easy. This is not the case usually, but I'm just using the number because it's an easy number. $100 a service. $100 a service, that means I pay $20 and the insurance company pays $80.
Right. Well.
Or sorry.
Yes.
Close to $80.
Yes. So just this 80% is not just because Lee's provider said, it's $100. The insurance company might say, well, 100 is kind of like not really the market. I think it's more like 75. So I'll give you 80%. Let's make it easy. Well, that's going to be a tough number. But anyway, 80% of 75.
Here, I could do it.
We're going to go for the calculator. So 80% of 75.
Hold on.
75. Oh, yeah. There you go. So insurance company says, we're not going to pay you $80. We're going to pay you $60 because we think 75 is about the right number. Then Lee's provider says, hey, Lee, I only got $60. Now his $20 now became $40.
Right.
So,
a
the
big mess.
provider, now think of this provider that has submitted this thing, saw Lee like a month ago, and now Lee paid him $20 up front because he thought, and now the provider is going to have to say, hey, I didn't get the full $100, so you now owe me $20. So we're simplifying these numbers and making it, but this is what deductibles and co-insurance typically deal with. The better
Correct.
policies has larger, the ratio has gone down over years to my understanding and talking to some individuals. So in the past, I think there were more 80, 90, 100% coverage.
Yeah, so I wanted to ask you about that. When we were at, when we first got out of school, there was the existence of what they called Cadillac plans.
Yes. So Cadillac plans is almost like a full, the provider asks for 100, they pay 100, and bottom line, and the patient doesn't have any out-of-pocket costs aside from their premium.
And they don't exist anymore, these Cadillac, or they're very, very
They're very rare, very rare.
Like unicorns.
Unicorns, they do exist, but they're very, for the average person, in-network has become much more a reality.
Yeah.
I believe with Obamacare, there had been, lots of policies created with the government subsidies, and I went, at least here in New York City, a large majority of them were in network. Not too different from some of the Medicaid policies, which really, to say that they pay below market rate is being nice. I mean, but there's certain policies that wouldn't even.
$15, $12.
Yeah, $12 to $15 an hour.
That's insane.
So yeah, I mean, I don't see there's just no logic to that. And again, it discourages people from, well, unfortunately, it will discourage a provider from dealing with that type of insurance. And then this patient will never really receive quality care. Now, luckily, some large institutions do take these insurances, and patients do get better quality than
On average.
Right? But the state of affairs in the last 8 years have really looked bleak, and it doesn't really look, I don't really think of it as getting any better. I mean, what I think will probably be happening is you're going to have people really off the grid, providers off the grid, and just saying, hey, we're going to go cash, and you'll deal with your insurance company. And it's overwhelming. I mean, if any patients are listening to this, it's overwhelming when you want answers to your benefits. I mean, there's often long waits, call centers that are not in this country that only have access to X information. So, I mean, overall, the insurance situation is really murky.
Yeah, it's tough. I mean, I do have to mention, because we have some insurance experts who work for us, and they're very helpful, extremely helpful. And when they communicate to the patient, and when I communicate to the patient, and I hear what, sometimes the patient will talk to their insurance company, and they have like a bullet point of information, and I'll go back to our insurance guy, and he basically just says that that's all untrue. That has nothing to do with their plan. That has nothing. He's like, they most likely, this happens all the time. He says they most likely just looked at their general, category plan, was like this, but they didn't probably look up their plan, and that happens a lot. It does. I mean, it has to be looked out for.
Yeah. So having perseverance and understanding reference numbers and who you're speaking to is really critical. But I mean, I just see the trend here in New York City, probably LA and Miami, any major city in United States. It's like quality providers that are kind of frustrated and just jump off. And there's enough wealth to feed those providers. And, it'll be a trend. I think hopefully this podcast is part of it. But just kind of getting back to reality and really not having to worry. This causes a lot of this in-network, out-of-network, and misinformation or information that very murky really affects the quality of treatment it affects the person's recovery rate, right? I mean, if they're already stressed because of an injury, and now they're having a financial stress of additional payments, or just truly not understanding, and then taking it out sometimes on the provider or the institution that's providing this care. They really can't get to the insurance company because there's multiple tiers to go through to actually speak to someone. So, it's a pretty frustrating situation, to say the least. But I would argue it doesn't have to be this way, and I think transparency is the most important thing. And as a provider, trying to educate your patient on this, although it's not your job as a provider, would be helpful. So that's why you kind of contract or consult with an insurance expert that will help you out with this. I mean, it's a cost, but it's a cost that I think pays for itself, quite literally, pays for itself because, it keeps everybody on the right page.
Right. And it's like Eric said, transparency is super important for this because you're already in a not so great situation when you're injured and going through this. The last thing you need is you need a prescription, you need a referral, you need to get authorization, pre-authorization. You didn't get your referral, your prescription is out of date. All these things, and that's all because the insurance companies, they wanted harder and harder to get conservative management overall. And it's to work around that, then we have to do other things like add a network and cash and things like that. And it's usually less stressful in the sense that you just go directly to the provider. If they have an insurance person, you speak to them about benefits, and then you can start treatment. You don't have these barriers that are not going to let you begin what you need to have happen.
Yeah, we've seen this countless times in practice, where patient doesn't have a referral, patient doesn't have a prescription, patient has run out of visits and they've been denied physical therapy, and they're obviously in need, and there's this, hey, insurance company said that I had 60 visits for the year. That's another thing we could discuss. Often policies have these limits on physical therapy, which I think should be in place. I mean, from a business perspective, they can't just provide infinite care to people.
Right.
On the flip side of it, telling a person, let's say they have 50 visits for the year, it is not also true. The fine print might say up to the discretion of the insurance company. They have to authorize the visits. So patients are like, hey, I thought I had 50. Why am I getting denied at 8?
No, it's amazing. I have to talk about these situations. It happens almost every day. And they'll have a panic attack, and it's understandably why they would, because nobody's explaining to them the way they need it to be explained. So they're like, so today is my last authorized visit. They said you have to do something, and I'm probably not going to get any more. And this happens all the time. So you have to be like, all right, so today is visit number 4, visit number 5. What I'm going to do is I'm going to do my usual documentation, write it, give it to our insurance people. They send it out, and it gets, quote, reauthorized for more visits. And unfortunately, we're probably not going to get the same amount back that we did the first round, but you're going to get more visits.
It's a descending kind of situation.
Yeah. That's right, yeah. So that's another thing, too. 60 visits. That first the first group of visits you get is, I was just telling Eric this story the other day. I actually asked for 16 visits with this one patient. I got 16 visits. This is the first time ever. I've been practicing for 8 years. We've seen thousands of patients. First time I've ever asked for a certain amount of visits, and I got that certain amount. It was incredible. 16 visits. So anyway, after that 16 visits, if that person needs more, which I hope they don't after 16 visits, the next round is not going to be anywhere close to 16. So if I ask for, let's say, 5 more, I'm probably going to get 2 more or something like that.
Yeah, it's a descending thing. I mean, another disturbing thing is when that's happening and there's a patient that's post-operatively, let's say they're dealing with an ACL repair, and I've seen this where I've asked for 16 visits or maybe even 20 visits, and I've gotten 7, 8. And this is for an ACL repair. Now, insurance company may say, well, where's the documentation? I mean, it's pretty common knowledge if you look at any kind of ACL protocol, what the amount of time it would be for a full rehabilitation. Now, granted, you're not going to take this person on a soccer field, 6-9 months later, but we're talking about the preliminary first 4 to 6 weeks after an ACL repair is pretty intense. 2 to 3 days a week would be advised, especially, the first few weeks. And, there's a barrier there. I mean, I've dealt with many people that have been denied after, 4 weeks, 5 weeks.
I think the worst case scenario I've ever had after an ACL reconstruction, they got authorized for 4 visits.
4 visits.
4 visits. And I had to talk to the support clinician, and they could not wrap their head around the fact that this individual, who wasn't like 60 years old, they were a little older than the average age for an ACL reconstruction, needed that many visits for it. And I'm like, this person just had surgery. They just had surgery.
They can't walk.
Can't walk. They can't bend their knee. They can't straighten their knee. They're not going to be even off of the crutches, for most part, after the 4 visits that you've authorized. Right. So they couldn't wrap their head around it. I was blown. That was probably the worst case scenario ever.
That was worse than mine. I mean, mine was a 6 to 8, and I remember the patient laughing. The patient was like, "Oh, it must be a mistake." And I was like, "No."
No, it was on purpose. And anybody who's listening to this is listening to my story right there and was like, "Oh, well, you probably wrote a poor document." I'll show you some of my motherfucking documentation. I swear.
Lee's a beast with documentation. He likes to write 6-page notes.
Yeah.
He tells you what the temperature is. He
I take the blood pressure.
Biometrics. He does everything. He gives color. He checks their tongue. He does a little acupuncture.
That's right.
No, but Lee's very thorough on his notes. So, yeah. That's not the case. Now, to that point, this is like the challenges of an in-network practice, right? So you're seeing 10 patients an hour. I'm just making some generalizations, guys. This may or may not be the case in most in-network practice. Let's just say they're seeing 4 patients an hour. They have to write notes. They have to eat lunch.
Wait, they can eat lunch?
Oh, they probably don't eat lunch.
No. See, and then this is all norm.
This is the norm. This is the norm.
I don't want to get ranty, but
he's going. His feathers are getting ruffled, man. But you write notes. You become a robot, and your notes do suffer. So then maybe it is the provider's notes that are not documenting enough progress, regress, or enough of an issue, I guess, for the insurance company to reimburse. But, we've talked about this on previous podcasts, but the investment in physical therapy, in my opinion, and the opinion of many others, that conservative management will save millions, if not, this billion-dollar kind of industry in surgery, medication, hospitalization. All that could be averted with conservative early management. And there's tons of research on this, of which I'm not going to post on the show notes. No. But there's tons of research on it. I'll give you a Google search and you can figure it out for yourself.
That's right.
But there's tons of information out there that conservative management will save time and money. And some insurance companies have gotten with the times and realize, wow, we're paying $50,000 for this surgery, and we're paying this therapist a couple of thousand.
Not even a couple thousand.
Not even a couple. Just 3 visits at the negotiated rate of $16 a visit.
We saved some money there.
Yeah. So there's benefits to early conservative management. But anyway.
Yeah.
Up to the next.
So we talked about in and out of network, deductible, coinsurance, out-of-pocket max. I would like to touch on how the billing goes out, because that can be confusing. I've had conversations with patients who were very upset about they thought they were like triple billed and things like that. So one of the additional things that insurance companies, and I think CMS, I guess that they kind of started it.
Yeah, Medicare. Yep.
Yeah. So they created to quote control costs is that they have timed versus untimed codes for physical therapy service, and I'm using the word service because this is the insurance lingo. So you're gonna have right now the main. Again, our expertise is in outpatient orthopedics. So the main codes being used are manual therapy, therapeutic exercise, I think you could still bill for ultrasound, but I'm not sure.
Neuro code.
So yeah, the
Even that's it.
neuro reeducation. So that's like the quote. Nobody knows that for sure, right? Like that's
No one
still
knows.
can't
I
use
know
it?
that it's a debatable thing, right? So neuro reeducation, if you take it in the in the sense that it is, let's say teaching a person a motor pattern, reteaching them how to work, technically would be a neuro reeducation. But I think in the eyes of possibly Medicare and or some of the larger insurance companies, a neuro code should only be used for a neurological deficiency. So stroke, Parkinson's, Alzheimer's, and any other neurological condition,
Right.
GBS. Yeah,
Yeah.
that. But I do understand that if someone, let's say, has a nerve injury like yourself, right? I mean, perfect example. How are you going to get the tricep? What are you really doing? I
The
mean, it's a neuro reeducation.
the exercises that my therapists were doing with me, they were hands on. Like he had his hands on me, and they were absolutely neuro reeducation. There wasn't like therapeutic exercise can be like a straight leg raise, 3 sets of 10. We weren't doing that.
Some tricep push kickbacks. He's like,
Yeah, try
bend over a little more, Lee. Extend your arm. Hold it. No, man, I can't imagine what he's cranking on it. Huh?
Well, he was doing like multifidus activation and very kind of like he had to palpate the motions that I'm doing with my occiput, and then he'll do like contract, relax, stuff like that.
Wild
That's
stuff.
crazy.
Yeah. So the codes, yeah. So these untimed versus time codes. So
Right.
the unit,
The unit. Oh, we love talking about these things.
units.
We worked with a handful of people who were just talking about this stuff all the time. It was great.
Units.
We gotta get so many units in one session, or else it's it's so bad. So
Oh man.
so a time code is the ones we listed off right there. The therapeutic exercise.
I can't, bro. I can't get it out of my head now. You know what I'm thinking.
Of course.
Oh man. Whew.
Okay.
All right. We're gonna keep it together. Keep it together. I can't even say the word anymore. This is bad. But no, I'm gonna let you continue. Sorry.
Okay,
Lee.
it's all right. So the time units were the therapeutic exercise, the manual therapy, the neuromuscular reeducation. I think therapeutic activities and things, modalities like
I don't know,
ultrasound.
is gait train? I mean, gait training's a code.
Yep.
But
That is timed.
that's timed.
Yeah.
Yeah. Okay. Cool.
So the time units, the time codes, they're billed by units. I know we keep saying that. So they're billed by how many units you have per that code, right? So let's say you see somebody for 30 minutes, and you do both manual therapy and you do therapeutic exercise. So let's say with the manual therapy, if you do 8 minutes of manual therapy, that's 1 unit. If you do 23 minutes of manual therapy, that's 2 units. So you're not double billing that unit. You're just billing how much time you spent doing that manual therapy. So let's say it was a perfect session. You
23 minutes.
23 minutes of manual therapy, and you did 8 minutes of therapeutic exercise. So you end up with what? 31?
Yeah.
31. So that's like a perfect, you hit 3 units total. So 2 of manual and 1 of Therex. That was like the dream treatment that you'll do every time, right?
Right,
So
the reps are perfect. It's the third set of leg raises. Here we go. 31 minutes. Have a good day.
I feel like the insurance companies picture people come in with like a screen on their chest, and it's just like a timer. As soon as you shake their hand, the timer starts, and then you can just watch the timer. Okay, it's been 8 minutes. Okay, 22 and 23, and we're done.
Lie on your back. Lift your leg slowly, 1 second at a time. So yeah, this unit thing is wild.
This is crazy to me. And how much sense does that make? 8, 23, 38 is the next one.
The next level up.
And I don't even know what 4 is. Do you know what 4 is? I haven't memorized it.
I think it's 53,
It's
Lee.
50 oh,
it's
that's
53. It's 53.
How did I not know that? I'm sorry.
53. And you got 7 minutes to recap the session, which you will not get paid for.
But you can't bill the same code 4 times, right?
I don't think so. That
That's Medicare.
That's Medicare. Medicare pretty much.
So we gotta
Medicare
we gotta pull something else from the menu. I gotta get the Therex, or I gotta get the Noried in
You
there.
gotta shine up the ultrasound machine, charge it up.
Oh, 23 minutes of ultrasound. That
Well,
would kill
dude,
the
what
person.
about the East? Yeah, man. What about ESTIM? That's a non-time code, or
There was a big argument at a clinic that I once knew, that the eSTIM there was a billable code, but the people who I've talked to who know about billing, they said no, you can't anymore.
no? That's
So
good. You
yeah,
shouldn't. I mean, if people can buy it, nah, it's a whole other story.
so
So
mess.
skilled, yeah, skilled. What is it? Skilled intervention.
Yeah, exactly. So that's the other thing too. How does one define these things? And it's manual therapy, for instance, is a skilled intervention that only quote a licensed skilled practitioner can implement, aka someone who knows what they're doing can do it, and they're worth that amount of units in time.
Oh, the
But
unit.
oh my god. So yeah, I won't even go into that. But untimed codes are things that are not obviously timed, but they recently changed it. The biggest code that we can implement that's untimed is an evaluation.
Oh, so you could take like 5 hours on this, or you could take a minute.
But you remember what they did when the ICD-10 came around?
Oh, you have to categorize this. Shit,
And if you
wow,
look
you
at the
totally threw me off.
oh
Yes.
Jesus, and you look,
Wow.
so
I
that is
totally-
another little sneaky thing that they did just to show like you can't undo it.
Now I'm thinking to myself, oh, all right, we got to go back to my notes. But
Nah,
no. But I think, yeah, they categorized the severity of an exam, whether it's moderate, severe, or complex.
Yeah, it's the complexities, but I think it's that. I think it's like very complex or severe. Like, I don't remember. There's three. There's three of them. Like the first one is the lowest. Oh, sorry, low complexity to high complexity. So, but if you read the descriptions, they're so ridiculous. The high complexity is basically like you have to include. I'm not saying this is ridiculous for the patient. I'm saying this is ridiculous that we have to. This will always be, they're going to give more money, by the way, for the higher complexity. And the higher complexity category, for instance, will include like a trauma, like a mental trauma, like a divorce, or like a recent loss that's in there. I remember going
It's
over it
fucking
with,
crazy.
oh my God, it was insane,
I
dude.
thought, and also like
Comorbidities and stuff like
exactly, like heart problems,
Yeah.
renal failure, whatever it is.
that. Yeah. And I understand it, but they're just so sneaky about it. Like, don't even put in the time. This is an untimed code, and if you're gonna split it up into complexities, great, leave it like that. Don't say like this high complexity should take you 45 minutes to do. Well, it might not. It may take me 60 minutes to do. It might take me 20 minutes because the person doesn't want to give over the information, and we might have to do more later, or they might not be able to handle 45 minutes.
Or they might just show up to their appointment 25 minutes late.
There you go. And I have a patient. I have 6 other patients right after them, and if I'm late with all of them, I'm not going to be able to bill those units. That's just going to sustain
Not going to be able to do his
my
notes.
salary.
Oh man.
Holy
but
shit.
one would ask why are these complex? Why did they break this up? ICD, that kind of leads us into the ICD-9 and ICD-10.
Oh, that's right. That's another one.
So basically, this is diagnosis codes, right?
Mm-hmm.
And the ICD-10 code, the most recent, is much more specific. I think it is more helpful. And if you are co-treating and you grab somebody's chart and you see right shoulder pain is a little more helpful than left, although people put it down in the wrong place. It's helpful knowing if this is a recurrent or chronic injury as opposed to acute, although that's not used because whatever. I think it is helpful, the detail of it. But I think the reasoning behind it is probably another topic we'll be discussing, but really like a data collection. And I think the data collection is going to be really skewed because of the complexities of a high volume practice. People aren't necessarily documenting for accuracy. They're documenting, one, to protect themselves, which documentation is there for, but also two, as to be efficient and to kind of be quick with it if they're seeing 100 people a day. So
yeah. And I wanted to touch on that a little bit. The more you work in this industry and the more notes you write, I feel like I'm like Rain Man when I'm writing my therapy notes. Like you do like you have an eval, right? write the HPI. Patient, 26-year-old patient presents with da 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 that began da da da. So then you reiterate that the assessment, patient who presents with da 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 da, and then like in the objective, you say patient is presenting. Physicians, when they like write a prescription for pain medication, they're just like, left knee pain medication, and
They don't give the range of motion. They don't tell you if it was pink or red. They don't tell you the person came in happy.
Efficiency of these things it could be very much easily remedied if you don't have to sit there and like you have to have those proper goals. You have to identify the patient. Every freaking goal that you have, the patient will perform like on the surface.
They still go over this shit?
Yeah, I mean like the ABCs. All you have the same. The goals will always be the same. The goals will always be the same. I can't emphasize that enough.
Get them out of the clinic. That should be your goal. To get the patient to be independent, to do whatever the hell they want.
Yes.
And you could just have one goal. Get the patient. That should be one goal. Please help the patient. I will help this patient in doing whatever they want within a reasonable amount of time. And that's that.
It is so nonsensical because it's like you write the same goals for the people. You're doing pain. I'm going to decrease their pain. I'm going to increase the range of motion. I'm going to increase their strength.
Yeah, they'll be able to walk 20 city blocks in 2 weeks.
And if you talk to an insurance person, they'll be like, well, everyone's a little different where you're going to like, no, it's going to be the same. And we're writing 8,000 notes in a week. So it's like we could just say, like you just said, get them out of the clinic so they can be a human being.
That's it. Get them out. Get them to do. They want to lift their child. They want to run a marathon. They want to compete in jiu-jitsu. Whatever it is, it's pretty simple. And it doesn't have to be that complicated.
They want to make it complicated.
Yeah, I mean, all this data. I mean, CMS, Medicare is big on collecting data. This all probably, skewed. It's sad because there's so many people that are on Medicare that really would benefit from quality care, and there's so many barriers for them. There's so many barriers, cost being the number one, but just filling out an intake form for some of our older individuals on an iPad, which they don't know how to use, and it doesn't have to be this. And there's some of the most appreciative patients that I've had, and I'm really lucky that I was able to help a lot. But it shouldn't be this complicated for anyone, for the providers, for the patients. And this is definitely a rant podcast, man. Sorry, but it's the truth, man. It
is. And I when I looked at the bullet points, I was like, "There's no way in hell we're gonna be able to get through this too fast without ranting."
No, but, I mean it. You know what? Because we've seen so many lives affected by it, including our own.
Yeah. What drove me nuts? Like what drove me nuts? What you just said right there with the excessiveness, what they have to fill out in the beginning. How we have to report once a year the BMI for the PQRS.
Please! Oh, the G codes.
Yeah, I'm not gonna. I won't get too much into it because I think this is
this. We will not cover this, but Google G codes PQRS. Yeah. Aren't they doing without it now? What?
You want to hear about that?
Yeah, I do. I want to.
Okay, so it was required for us to report these PQRS codes, which include the functional G codes, for 2016. I think it started when they implemented ICD-10. But 2017 and the current year, 2018, it's optional. It's optional.
Oh, I would include them.
But
I don't need 5x 10 minutes. Come on.
10 minutes. It's like 30 minutes.
30 minutes. I would just include them just so the government has the data they need.
I know, right? So that's what these people are doing. They want us to include them. They want us to include them.
Just in case.
Just in case. And it's so ridiculous.
Data points. Data.
But one of them includes the BMI, right? So BMI is height and weight, which we don't even have an EMR that will automatically calculate that. That's number one, which is crazy. So the patient legally cannot just put in their height and weight.
You got to check it out.
We have to do it. So we had to get one of those things in the doctor's office that you have to step on and measure.
It's a scale, dude. It's a scale, and I don't even know. I know it. I don't even.
It's called a certain
It's
thing.
a ruler. We use a ruler and just measure up on the wall. Oh, that's hilarious. That was great. It was like one of those things they get on.
This is how crazy it
Oh
makes
man.
me, man.
No. It's. I'll never forget when. I'll never forget. When was like, all right, we need a scale.
Oh my God.
And can we? How many hours would like talking to EMR people about just setting a little
Getting the
algorithm?
scale, I don't know, man. After we got it, I had a couple patients, and when you treat Medicare patients, they're not usually the most mobile. So you walk them over to the scale, and then they almost fall getting onto the scale. So you have to sit there and
Just-
guard them, and they're having trouble just getting on the scale. Never mind walk. And so now, like, you really think, what are we doing here? Like, what is this doing for us? If I'm gonna be taking the patient's time and like risking them to fall off the scale, and I know I'm a trained individual that can prevent them from falling, but like,
But why aren't they on the table? Why aren't you educating them? Nope.
let's spend more time educating. Let's spend more time talking to them. Let's spend more time finding out what's going on with them.
Now we know as healthcare providers, the BMI.
Oh, it's the most accurate motherfucking thing you can ever get.
BMI. So if you took a powerlifting 7-year-old and put him on the scale, he's gonna come up like, wow, this guy's a little overweight, buddy.
He's obese. He's probably in the obese category.
And you're gonna tell him, hey man, I know your knee hurts, but all of us know we understand body composition, we understand other factors in lifestyle, but measuring someone's height and weight is.
And if you're going to reimburse that little, and then we can't even have assistants to bring them over and get these initial measurements, and we have to spend their time with us to do this, then you better come back with some serious like benefits of all these numbers, which it has not happened in these last 2 years.
No, so data is important, and obviously data could reveal certain patterns that exist naturally in nature, whatever, in time, but real time, on the floor, patient has X time in a clinic. These requirements, these Medicare requirements, are very they're really distracting from what's really, in my opinion, what's important, care. Now I understand government wants to quote reimburse. This goes into our other point. Reimburse providers that have quote good outcomes. And just that alone, there's a problem. There's an ethical problem of reporting, right? I mean, people are reporting people getting better. They're not getting better. Or maybe they're getting better. They're not being reported getting better because they want to keep them on the list. Now, these are, unethical providers, which unfortunately there's tons of. And, with Medicare, there's been all types of fraud committed. And again, to those people that are, in that boat, that these fraudsters they're really killing it for everyone else, and it costs everybody. It costs the government, it costs the patient, it costs the provider. So, that needs to get worked out on the private insurance as well as the public. If anybody's committing crimes, they shouldn't be treating.
Right. We had that example that was in the previous podcast, but the guy with the Medicare fraud.
Oh yeah, he was treating dead people. He had Social Security numbers and I think it was like 12 an hour, 15 an hour, something
like that.
So it was something like the richest physical therapist in New York, some horrible.
And that was back in the day when you didn't even hear about physical therapy, and the only time you heard it was in that stupid article they wrote called "Treat Me but No Tricks, Please," and then that other article, the Medicare fraud. So it was like it paints a really great picture about physical therapy. But now, luckily, there's been some hardworking Australians and New Zealanders who's really pushed physical therapy on the forefront. So,
and we're here now trying to educate the public,
educate
providers, educate whoever wants to be educated on what it looks like in the trenches, pretty much.
It's true. So, I mean, these are some barriers that I think can be, restrictive for someone receiving physical therapy. To talk about the good, because we already talked about the bad and the ugly, I think. Actually, we didn't even talk about the ugly. I don't want to go too much into the ugly, but there's a lot of ugly stuff. But some of the good, obviously the good is, with health insurance in the United States. I was listening to This is part of the podcast. We start talking about other podcasts.
Right.
I was listening to Joe Rogan talk to this individual. I can't remember her name off the top of my head, but it was one of the new ones that he had, and she was on the carnivore diet. And she was overcoming autoimmune disorders, and she's Canadian, and she was talking about how the medical system is not great there, and she was explaining the logistics of actually getting orthopedic surgery there and things like that. So definitely insurance here, and when you're talking about serious conditions, you can, if you have insurance, you can, if you have access to it, you can get good quality care.
In a timely manner, right? I mean, I guess the argument against a single payer system like in Canada and certain parts of Europe is that the amount of time it would take to get care, like imaging, for instance. In Lee's situation, had a neck and nerve injury, went to a provider same day. You know, we do have a cash and carry system still, so he was able to pay cash for his, and from there was able to get an image relatively quick.
Yep.
So these are the pros of the enormous amount of money we're spending. We do get some top-notch health care delivered in a timely, depending on your situation. Emergency medicine being probably the best in that, we make people wash their hands in the hospital, and it helps, a lot,
That's
but no,
right.
I mean, I don't want to oversimplify it, but the bottom line is we have an amazing medical system that can take care of certain things. Yes, that has the issues like any other system anywhere in the world, but comparing it to, let's say, a universal system like Canada, what was this woman saying?
She was talking about she had an ankle replacement. She had a very interesting story. I mean, he always has interesting people. She was 26 years old, had a severe, like most of her life, had severe autoimmune conditions. And then because of that, when she was 17, her hip degenerated. I can't even say that word anymore.
Degenerate. Well, he doesn't like it. That's why. I know your brain is trying to erase it. It's like degenerative means age-related changes.
That's what I want.
Age-related changes.
That's so weird, man. My brain is totally fucking
You don't
with
want to
me.
say it.
Degenerative changes.
Oh,
I swear I'm not having a stroke. Her hip was wearing down.
Yeah, that's good.
At the age of 17, and she had to have she had a hip replacement, and then apparently the same thing happened at her ankle, and they replaced her ankle. But now, since she's gotten older and more active, the material that they used for the ankle wasn't very good, and she wanted to get possibly some new material, and so she didn't go back to the people in Canada, because if she did, she would have to wait, for a very long time. She said something like 3 months, I want to say. So she's gonna go to some doctors that she heard about here in New York, in the United States, and she said she would be seen within the month after an evaluation. So definitely it's gonna be a timely thing.
Yeah, I think
you want to get surgery.
Yeah, it's, again, pros and cons. We're trying to be relatively unbiased.
We're very biased.
Yeah, we're definitely very biased. So in terms of reimbursement or information, that leads us to another topic where if you are, you don't have a contracted rate and you're not an in-network provider, you are subject to the insurance company's interpretation of what is usual and customary. And that varies, obviously, according to city, state expenses. And here in New York, we, have the ridiculous cost of living. So obviously the reimbursement rate's a bit higher. But again, that's subject to the insurance company's discretion, I guess, right?
Yeah.
So there's an interesting thing where, you could bill an insurance company, I don't know, 4 units, and the insurance companies would say, well, this patient has seen multiple providers in the last month, and it's called a multiple procedure reduction. Don't ask me what that means. I've yet to find out. But essentially, we'll just pay you for 1 unit.
They're just creating things.
Just creating. So obviously, you have your billing team or whoever you use for that, or maybe even yourself. You might just do the billing on your own, which is a sure way to a heart attack. So you may call the insurance and like, well, yep, your patient, your patient has seen multiple doctors, and this is a way to consolidate, because they've doing. So anyway, it goes back and forth, and then that leads to the next bullet point, which is the delay game. Insurance companies typically with patient reimbursements too. So if you're an out-of-network provider and provide a receipt to your patient submits it to insurance, they may receive reimbursement as soon as 2 or 3 weeks, which is kind of a unicorn. More likely it'll be probably 6 to 8 weeks. And they may have this multiple procedure code or whatever have you. I mean, whatever they could concoct at the time. Another delay game is in third party. So you call customer service, and customer service is now this third party company potentially. I'm going to use India as an example, but it could be Brazil. It could be, I don't think it would be China. It could be somewhere. It could be a call center somewhere else. But typically, you're getting thrown to different departments, and you may leave a message. And so the luxury of time is obviously on the insurance company's side, because they have time and money to burn. So
They do.
And eventually patients kind of just give up, or providers might say, well, I'm just going to forget it.
Yeah.
And then, and that's how the margins are increased.
I think they've mastered this game, by the way.
Yeah, it constantly evolves.
They're becoming black belts in unacknowledgement, delays, degeneration.
Degeneration.
I said it!
Oh, degeneration. Degenerative practices. Degenerative practice.
Degenerative practices.
Degenerate. That's really what it is.
It's crazy, man.
But the game is crazy. So to those patients, providers, or any listener out there, it's a challenge, but you just gotta stick with it, And unfortunately, I do see the trend where there will be a time where it's just like providers, quality care, confident, well-versed providers will say, "Sorry, I don't accept insurance."
Right. And the tables will turn.
The tables will turn.
Yeah, it'll be very interesting. I hope I'm alive when it happens, because the way things are going, it's taken a long time. But we talked about it already. There's more and more people coming out of school who are not going in the insurance game, which is fantastic. And there's a lot of people that we know in our close circles that are transitioning into out-of-network, so they don't have to have these barriers to treatment, because they actually want to help people. They actually really care about patients, and they really want to give them the best that they can give them, and also use the education that they paid a lot of money for to do, and they worked really hard for.
Yeah, so this specialized knowledge that's kind of out there, specialized knowledge doesn't seem to mean much nowadays with Google, but it does mean now more than ever with the amount of information that's out there. I think it's our job as providers to help navigate all this information. And like Lee just said, the reason we might be ranting is because we really care at the end of the day about patients' well-being and truly trying to help people. And it's unfortunate that many providers and patients have these barriers. And if there's any kind of serious healthcare reform, these barriers need to be addressed in a mutually agreeable fashion, or you just cash and carry.
Right. And this, I guess, what bugs me a lot is, and I think I've been going over it in my head for a long time now, ever since we started the podcast, and even last year. And I think to myself, why am I thinking like this? Why can't I kind of like play along with this little game and be okay with it? As I see sometimes a lot of therapists are totally fine with this, and they're just like, well, we're not going to be able to do that for you, but I think I've had some really early influences before my PT career that kind of showed me behind the curtain and like what it can be. And that always stuck with me, and not in a bad way, just in a way that like, well, wait, this doesn't have to be this way, and why aren't we working towards it? So sometimes when I see therapists and other people who are non-physicians, where they're just like totally okay with the game, and they're kind of not gonna say cooperating, but they don't seem to want to like have a change happen.
I think it's all perspective, and I think what Leah's mentioning of people kind of going with the flow.
Complicit. That's what I meant to say. I'm sorry.
Complicit.
I learned about that recently. So.
Complicit. He's sharing his knowledge day to day. But yeah, there's a lot of complicit. I think it's complicit, and they definitely don't see the big picture.
Yeah,
it's taking a step back and like, oh, this is the way it has to be. This is it. This is what they do. They deny, or this, and it doesn't. Oh, people would never pay for out-of-network. People wouldn't pay cash. Why would they pay cash when they have insurance?
A lot of people do, and there's a reason why.
There's a reason why. They value quality, and I think...
And now that what I'm happy about is now there's enough research to show that what you were saying before, these early interventions, conservative management, are going to have huge cost differences when you see someone who is high quality and get good education. And now we can say, like, well, look at this. These numbers show it. Evidence shows it. Because anytime you talk to an insurance company about this stuff, they're like, well, the evidence shows that they're not within the normal ranges of motion of their shoulder, or they are within the normal ranges of motion of their shoulder. Right. Well, have you read evidence lately?
Right.
Do you know what a kettlebell is? Do you know what a squat and a deadlift is? Can you get off the toilet?
Can you cross-collar choke? No. That's out of the scope. But no, it's and that's another
this is crazy.
Point on data. Data doesn't equal truth all the time. I know Correct. Some people connect the data truth connection, or some of it is correlation. And there's not causation. So it's really hard, with all the data that is being collected, it's really hard. Certain assumptions are hard, especially when you're talking about humans, human interaction, human relationships, the human body. Really hard. Really. Yeah. We're not cars.
No, we're not cars. And it's only now coming to light that there's a brain attached to the body.
It's very complex that we only scratch the surface on understanding.
That's right. Yeah, I think that we kind of touched upon this stuff. We always talk about it a little bit in each podcast when it comes to insurance, but we wanted to at least give like a full background. And I guess also to talk about suggestions and how they can improve.
Yes.
We love to give suggestions. I think number one, we talked about this before. Don't have a timed unit for our treatment.
Right.
Have a
flat rate.
You see the physical therapist for a follow-up. Bam. That's it. And I've talked to a couple PTs about this, and they're like, well, then that would make it worse for people committing fraud. Then people, I'm like, no, that'd be easier to figure out. Because if you have someone who's reporting, I'm seeing 20 patients a day.
It's impossible. Right.
Versus someone who's seeing 4 patients a day, 5 patients a day, whatever it is. Who the hell do you think is committing fraud and or doing really shitty physical therapy?
Right.
Or not physical therapy, really shitty treatment.
Right. Or whatever you want to call it.
Yeah. So, I think that's number one. I think number two would be to actually reimburse a rate in network that is reasonable. And I think on average, the rates that I see, the quote in network rates that we used to see back in the days, no, they're not reasonable. They're not reasonable for the information that we're giving the patient, time we're spending with the patient, and also what we're offering.
And in terms of like this credentialing policy, really having, as Lee mentioned, maybe in that credentialing policy, really getting an interview on a provider. Interview him.
Yes, right. Nobody was interviewed with those things.
No. Interview the person. Is there a background? I shouldn't say that. There's probably some kind of background check on people with credential. I really hope
they check your phones.
They follow you around for 3 weeks.
They read.
They go through your garbage. They really make sure you but really like grabbing, I guess, really rewarding excellence, and that's something. You could kind of reward yourself for excellence because you could dictate a certain rate. You could do that, but if you really wanted to have a cohesive system and have these quote negotiated rates where they don't go bankrupt because they're paying out more than they're bringing in, which will never happen.
Mm-hmm.
and vice versa, the therapist could actually have a decent living, so, I mean, coming to a middle ground, and I don't think we're at a middle ground, unfortunately, because it's just, I don't think everybody understands all the factors at play.
Correct. Yeah, and it's too. If you talk to people about insurance, when it comes to PT, the first thing they usually say is, "Well, it's really complicated." It's really complicated.
Many people have said that. Yeah, it is. It's very complicated. But we're open to suggestions. I mean, we gave you a few right there. Yeah. But definitely a good discussion point. If anybody has any recommendations, you want to share your thoughts.
And those are the simple recommendations. Damn, I mean, I have a lot more, but that would get into the complexities of our existence and Western civilization.
Really would. But I think I'm optimistic. I'm optimistic that a middle ground can be achieved, and which everybody's somewhat mutually happy. And most importantly, patients are getting better.
Yes.
Patients are getting what they need. Whether that's education, whether that's whatever it is they need, it just keeps them out of harm's way.
Right, exactly. All right.
Signing off.
It's gonna do it for us today. Thank you for listening. Signing off.
Thank you for listening to A Few Good Physios. Follow us on Instagram, Twitter, YouTube, and Facebook. Follow us each week while we interview guests and have clinical commentary.